Good morning, everyone. Today's topic is transesophageal echocardiographic assessment of cardiomyopathies. I myself, Dr. Chantal Bhandari, working as an assistant professor in the Department of Cardiac Anesthesiology at UN Mehta Institute of Cardiology and Research Center, Ahmedabad. What is cardiomyopathy? American Heart Association defined cardiomyopathies as a heterogeneous group of diseases of the myocardium associated with mechanical and/or electrical dysfunction that usually but not invariably exhibit inappropriate ventricular hypertrophy or dilatation and are due to a variety of causes that are frequently genetic. The World Health Organization identifies 5 classifications of cardiomyopathies: dilated cardiomyopathy, hypertrophic, restrictive, arrhythmogenic right ventricular, and unclassified. We'll discuss it one by one. Now coming to dilated cardiomyopathy. It is the most common of all the cardiomyopathies, and it manifests as a dilatation and impairment of systolic function of one or both ventricles. So basically it occurs secondary to the coronary artery disease or the end-stage regurgitant valvular diseases. There is a progressive decline in myocardial function with fibrosis and necrosis leading to ventricular dilation and further worsening of myocardial function. It is often diagnosed in the presence of decreased LV ejection fraction less than 30% and marked LV dilatation. End systolic and end diastolic volumes are typically increased. So the common echocardiographic findings in dilated cardiomyopathy, it includes the dilated left or right ventricle, global hypokinesia, there is atrial enlargement, dilated mitral annulus with mitral regurgitation, spontaneous echocontrast in the left atrium, diastolic dysfunction, and decreased stroke volume and cardiac output. So this is a dilated cardiomyopathic picture. The LV is too much dilated. Here the LV occurs, looks like globular rather than spherical. And there is a dilatation of the mitral annulus leading to mitral regurgitation. This is how the echo looks. Now, diastolic dysfunction of the left ventricle, usually there is a restrictive pattern in this. There is increased E by A ratio and shorter transmitral A wave ratio. Because the LV is dilated, there is increased LVEDP, and that will lead to increased E by A ratio. The decreased E wave deceleration time, and there is a blunting of S waves in the pulmonary wave. As you can see here, the E wave is much more than the A wave. So there is increased E by A ratio. I am not going detail in the diastolic dysfunction as we have already conducted a class previously. Next is hypertrophic cardiomyopathy. It is the most common genetic cardiac disease. There is a LV hypertrophy in the absence of other cardiac or systemic disease. And echocardiography is a preferred non-invasive method to diagnose the hypertrophic cardiomyopathy from hypertrophic obstructive cardiomyopathy and to differentiate them from the left ventricular hypertrophy. So there is a left and a right ventricular hypertrophy which is usually asymmetric, and it involves the interventricular septum. The common echocardiographic findings, it includes the septal hypertrophy as you can see in the diagram. So more than 15 mm, and it is usually asymmetric. There is a LV hypertrophy, global or focal. There is a systolic anterior motion of anterior mitral valve leaflet. There is a left ventricular outflow tract obstruction and dynamic pressure gradient across LVOT and turbulent flow in the LVOT with late peaking gradient. Like in mid to late systole, there is a gradient which is dagger shaped and continuous wave Doppler, and diastolic dysfunction. So this is a normal heart-line hypertrophic cardiomyopathy. There is a thickened ventricular septum as you can see in the diagram. So there is a the mitral valve leaflet. So there is a systolic anterior motion of the mitral valve leaflet can occur, which will lead to the obstruction across the LV or reduced flow across the LV and leading to the LVOT gradient. Now this is the dagger-shaped gradient across the LVOT we can see in the deep transgastric long axis view. This gradient occurs in the mid to late systole, and the shape which can view in the continuous wave Doppler is this. So dagger-shaped appearance in mid to late systole, and it shows about the gradient across the LVOT. Now, in HOCM or in hypertrophic cardiomyopathy, exact measurements of the outflow gradient and septal thickness and careful assessment of mitral valve we have to look for. The distance from the aortic wall to the point of septal contact should be measured to ensure the appropriate resection. and the anterior displacement of the mitral valve, which causes the mitral leaflet septal contact and subaortic obstruction and development of the funnel-shaped interleaflet gap leading to MR. It is a posteriorly directed jet which peaks in mid to late systole. Measurements of mitral annular diameters and leaflet lengths, like the posterior mitral leaflet length more than 15 mm, it is a predictor of systolic anterior motion and it should be made. And mitral valve prolapse and leaflet restriction should also be communicated to the surgeon for appropriate resection, and predictors of SAM should be noted. And the diastolic dysfunction is secondary to that hypertrophic myocardium. Findings may include the prolongation of isovolumic relaxation time and abnormal relaxation and decreased E/A ratio. Nowadays, 3D-TE may allow for the assessment of the extent of maximal septal thickness, the degree of LVOTO, and the extent of systolic mitral leaflet to septal contact. And following septal myomectomy, the role of TE is for the adequacy of the septal resection. We have to look for whether VSD has occurred, ventricular septal defect post-resection. We have to look for the mitral valve and its anatomy, and for the severity of residual MR, and for the SAM of the mitral valve. Now next is the restrictive cardiomyopathy. It is the rarest of all the cardiomyopathies, and it is characterized by the restrictive filling and impaired ventricular relaxation, usually in the presence of normal systolic function. So diastolic dysfunction is more prominent here. Non-dilated ventricles with normal systolic function, and there is no regional wall motion abnormalities. Common echocardiographic findings, it will include the impaired ventricular filling, biatrial enlargement, diastolic dysfunction, normal ventricular size and wall thickness, but normal systolic function. So diastolic dysfunction, it manifests as impaired ventricular filling and elevated filling pressures. So there is an increase in the LA pressures and increase in the LVDP, and that will lead to the shortened isovolumic relaxation time, increased transmitral E/A ratio more than 2, and shortened E-wave deceleration time, usually the restrictive filling type 3 diastolic dysfunction, systolic blunting of pulmonary waveform, and decreased color M-mode Doppler propagation velocity less than 55. So these are the stages of diastolic dysfunction which are discussed already in the previous lecture. So as the grade progresses, like from the impaired relaxation to the restrictive pattern, initially the E/A ratio is less and increased deceleration time is there, but as the disease progresses, or in the restrictive cardiomyopathy, there is an increase in the E/A ratio and decrease in the deceleration time, and there is a blunting of the S wave in the pulmonary vein Doppler. Echocardiography is often performed to distinguish the restrictive cardiomyopathy and constrictive pericarditis. Both have preserved LV function, but in constrictive pericarditis, there is a pericardial thickening and relatively preserved diastolic function. Mitral annular tissue Doppler velocity is more than 8 cm per second. Atria are usually non-dilated, and septal bounce you can see. Now, arrhythmogenic right ventricular cardiomyopathy, there is a progressive fibrofatty replacement of the RV myocardium. There is a strong familial association in this and presents with the symptomatic arrhythmias or sudden death. Sparing of the ventricular septum is frequently seen. On echocardiography, we can see the RV enlargement or dysfunction and diastolic outpouchings and systolic aneurysms. To summarize, echocardiography is a useful tool in the assessment of the patients of cardiomyopathy, useful to assess right and left heart function, determine the underlying etiology, screen for associated pulmonary hypertension, and increasingly used to aid prognostication and guide the treatment. Thank you.